Today's guest is Dr. Edu Herrera, medical doctor graduated from Universidad de Guadalajara, currently faculty and coordinator in the International Program of Medicine of that institution. For those who are joining for the first time, what we hope to achieve from these meetings is an understanding of the topics and to develop a series of steps we can take individually towards the theoretical or practical outcomes we want to achieve in the medical field. This meeting is scheduled for 25 minutes with a 5-minute question section at the end of it. I will leave you with my friend who happens to have a beautiful brain to share a lot with you on this hemato session we have prepared for everyone.
Okay, so I am going to talk about a little bit about acute lymphoblastic leukemias. I am going to do it from the standpoint, okay, of any healthcare practitioner. Okay, I know that the public in this particular case, we all come from different academic backgrounds. Um, we are mostly going to talk about the diagnostic approach. Okay, everybody, okay, associated with healthcare should be able to uh, make an opportune diagnosis, which is extremely important, okay, in these particular patients who can present these. Let me see if I can share my screen now. Excellent. I can. All right. Does everybody see my presentation?
Yes, we can.
Thank you. All right. So let's get started. So this is a comprehensive review, okay, to the correct diagnostic approach to acute lymphoblastic leukemias. All right. And so first of all, we need to define what are acute lymphoblastic leukemias. So simply put, this is a tumor of the blood and of the bone marrow. Now, how does this become a tumor? Well, for this, we need to talk about hematopoiesis, okay, a very important physiological process, uh, which is very important for the formation of our blood components, white blood cells, red blood cells, platelets, okay. In this particular case, we want to talk about the differentiation of lymphocytes, okay. We have T cells, we have B cells, plasma cells, we have NK cells as well. Okay, so as simply put, that's what an acute lymphoblastic leukemia is. It's a tumor of the blood and of the bone marrow. I love this image. You can find these images on comic.com, which gives us, the typical presentation of an acute lymphoblastic leukemia. And I also like their definition. This is a clonal proliferation of neoplastic immature lymphoid cells. Now we're going to break down that definition in the next slide. So for this, we need to talk about hematopoiesis. And we already mentioned that term. Hematopoiesis is a very important process where we have one universal precursor cell called our hematopoietic stem cell or our blood stem cell, okay, more simply put. Now, this hematopoietic stem cell is going to differentiate into two general lineages, myeloid lineages or lymphoid lineages, right? Here, we're going to focus on the lymphoid lineages. I am going to mention myeloid really quick. Myeloid progenitor cells will give rise to the red blood cells. Erythrocytes will give rise to megakaryocytes, which eventually give rise to the platelets and give rise to the granulocytes, our neutrophils, basophils, eosinophils. Okay, but like I said, we're going to focus on the lymphoid progenitor stem cells. Now, the lymphoids, this image is very summarized. It's very simple, okay? This is actually a much more complex process. Our hematopoietic stem cell, when it differentiates into a lymphoid progenitor cell, okay, later on we'll differentiate into a lymphoblast. Particularly, I want to focus on the precursor or pre-blast, okay, pre-B cells and pre-T cells. Now, this differentiation process is, like I said, is highly complex. And of course, it is prone to error, specifically genetic error, meaning, okay, there can be a problem in the differentiation, okay, and subsequent proliferation of these cells, which can lead to the arrest of differentiation, meaning in acute lymphoblastic leukemias, these precursor cells do not evolve into more mature lymphocytes, T or B cells. Okay, they become arrested at an immature stage. Okay, And once they become arrested, they actually start to expand. Okay, this is called clonal expansion, clonal proliferation, meaning this immature white blood cell or this immature lymphoblast in this particular case starts replicating itself, okay, and it starts accumulating within the bone marrow. Now, this is going to lead us to, okay, acute lymphoblastic leukemias. It can be either B cells, T cells, or very rarely, okay, we can actually have other types of acute lymphoblastic leukemias associated with NK cells, etc. All right. So remember, keep this term in mind, hematopoiesis. Now, and before I go on, we need to talk about where does hematopoiesis originate? Okay. Well, we know that in the newborn in the adults, okay, we have the bone marrow, specifically the exoskeleton. Uh, and the prenatal life, okay, around 2 to 7th month of prenatal life, the liver is the main hematopoietic organ. Now, why am I mentioning this? Because even though the bone marrow is the prime or primary site of hematopoiesis, there are extramedullary sites of hematopoiesis, such as the liver, the spleen, lymph nodes, etc. Why is this important to mention? Because this is going to give rise to some of our very important clinical signs, which we'll see next. Now, this is another image. You can find this in the pathology book, Robbins. Okay, hopefully we'll have a new edition coming out this year. And where we're going to see the differentiation of these pre-B cells and pre-T cells. On the left, you can see here in the bone marrow, we have the differentiation of our B cells. And I'm going to focus on the B cells. Now, the pre-B cells do mature in the bone marrow, okay, and then they later on they continue maturation in the peripheral lymph nodes, okay, in the germinal centers. Eventually, they can become plasma cells. Here, we start having, okay, arrested development of our pre-B cell, okay, and this arrested or immature lymphoblast starts proliferating, okay, and this is what leads to the formation of a tumor within the bone marrow. Now, keep this in mind. When we talk about ALLs, 85% of ALLs are associated with the B lineage, meaning we have B cell acute lymphoblastic leukemias in 85% of patients with ALLs. The rest, 15%, are mostly T cells, T cell ALLs. And we know that T cells will mature within the thymus, okay? These can actually present as a peripheral lymphoma. All right. So let's talk a little bit about the epidemiology. The epidemiology here is very important, not just for diagnosis, also for prognosis, okay, and classifying patients. There are approximately 6,000 new cases of ALS a year. This is taken from the data in the United States. Half of these cases occur in children and teens. Children tend to present with B cell ALLs. Teens tend to present with T cell ALLs or T cell lymphomas. Okay, this is unfortunately the most common cancer in children. This is also the most frequent cause of death from cancer in patients younger than 20 years of age. However, fortunately, okay, uh, in most cases in B cell ALLs, these tend to have pretty good prognosis, especially okay with aggressive chemotherapy treatment. Peak incidence does occur in younger children, 3 to 5 years of age. Okay, this could be expanded from 2 to 10 years of age. Uh, Definitely not as common in older adults. In adults, we tend to have other type of leukemias, okay, and lymphomas, such as chronic or acute myeloid leukemias. Chronic lymphocytic leukemias tend to be more common. Peripheral B-cell lymphomas also tend to be more common in adults. So clinical findings, this can be very varied. There are many clinical presentations. They may be non-specific, okay? A lot of these findings can emulate self-limited childhood diseases. It's, one of the most common presentations is a young patient that has recurrent upper respiratory tract infections, right? However, if you start seeing a recurrence, okay, of a patient with infections, then you would want to take some lab tests. Probably the first lab test you want to take is a CBC, and this is where we might start seeing some irregularities. In fact, up to 6% of ALLs may be diagnosed in asymptomatic patients. These were probably diagnosed in patients that underwent routine labs. Once again, what made us think of this diagnosis is going to be specific irregularities in the complete blood count. Now, in the typical presentation of an ALL, okay, they usually present these typical clinical features, okay? Now let's try to make sense of each of these. So in about 65 patients upon diagnosis, they tend to have hepatomegaly, okay, meaning increased size and tenderness in the lower right rib cage of the liver, right? Now, why might there be hepatomegaly? This might also be accompanied by splenomegaly, which is enlargement of the spleen. Remember, these lymphoblasts, okay, which are proliferating within the bone marrow, okay, are going to suppress hematopoiesis in the bone marrow, meaning it's if the bone marrow can't produce healthy red blood cells, white blood cells, platelets, then other tissues are going to start taking that assignment, right? This is called extramedullary hematopoiesis, and this can lead to enlargement of the spleen and of the liver, okay? This can also lead to enlargement of peripheral lymph nodes, okay, which will be seen manifested as lymphadenopathy, okay? For example, enlargement of cervical lymph nodes, inguinal lymph nodes, okay, axillary lymph nodes, etc. Now, one of the cardinal features of LLs is recurrent fever. Now, fever can present, okay, due to two main reasons. One, we already mentioned that there is going to be suppression of hematopoiesis within the bone marrow, which is going to lead to pancytopenias, especially neutropenia, which is a decreased production of neutrophils, which is the most abundant white blood cell. This suppression of the formation of neutrophils will lead to neutropenia, which will lead to increased risk of infection, which makes sense because these patients typically have recurrent infections, which can also lead to fever, right? However, fever can be associated mostly with the actual lymphoblasts that are secreting cytokines. Cytokines such as IL-1, IL-6, okay, which are acute phase cytokines, can lead to the presence of fever, recurrent fever. Now, one of the most important and most general lab studies we can take, okay, and it's pretty quick, okay, to do, is a complete blood count. Uh, Patients with LLs usually have very specific irregularities in a complete blood count. Now, what do we see in a complete blood count? Well, in general, we see three things. We see red blood cells, erythrocytes, and its hemoglobin. We see white blood cells with a different about white blood cells. Remember, we have neutrophil lymphocytes, monocytes, eosinophils, basophils, right? Uh, some of these, sometimes it can be increased, sometimes it can be decreased. Neutrophils, for example, will usually be decreased. And platelets, we're also going to see a decrease in our platelets. Once again, because the lymphoblasts are taking up the bone marrow. So the bone marrow can't produce healthy red blood cells, white blood cells, and platelets. And one of the other clinical manifestations, and this is probably one of the reasons that will lead a patient seeking medical help, okay, or evaluation, is the child will present with bone pain. It can also present in adult, but child usually present with bone pain. They can present with limping, okay, or an altered gait. Many times the child will not want to bear weight, okay, on the site that is affected. Less common clinical manifestations, but we do need to take good evaluation of is central nervous system manifestations such as headaches or head rigidity, okay, due to the CNF infiltration of these lymphoblasts. In some male patients, usually less than 1% of patients that are male that present with ALLs present with testicular enlargement, so we should evaluate that as well. And mediastinal masses can present especially in teenage patients or young adults associated with T-cell ALL or T-cell lymphomas. Mediastinal mass, as we know, can lead to superior vena cava syndrome. They could also lead to respiratory symptoms. So this is not as common, but it's something we should look at. So manifestations associated with abnormal CBC, like I said, this is the staple of diagnosis, right? Okay, anemia, okay, which, like I said, we know we're going to have anemia, we know we're going to have thrombocytopenia, and we know we're going to have altered white blood cells because the bone marrow is not functioning properly. So patients who present with anemia, okay, are going to manifest pallor, fatigue, headache, dyspnea. Patients, okay, will present with thrombocytopenia, and its clinical significance is going to be represented by easy bruising, bleeding, petechias, purpuras, okay? In most cases, upon diagnosis, we see thrombocytopenias usually less than 100,000. We know thrombocytopenia is defined as less than 150,000 platelets, okay? But like I said, upon diagnosis, usually we see a more significant thrombocytopenia. And white blood cells. Now, this is actually not only associated with diagnosis, but also associated with prognosis. Fortunately, in most cases, the initial white blood cell count, we're going to see a total count of less than 10,000, even though this might be associated with neutropenia. This is actually associated with good prognosis, okay? But in many cases, we might actually see a patient already with leukocytosis. Now, remember, why would we have leukocytosis in a patient with acute lymphoblastic leukemia? Because we, in fact, do have a large number of lymphoblasts, okay, that originate in the bone marrow, but are now leaking into the blood circulation, leading to leukocytosis. Now, this leukocytosis is going to be at the expense of lymphocytosis, which will lead us to doing another, okay, test, which is looking under the microscope. We need to see a peripheral blood smear. We need to see what is causing this leukocytosis, okay? And we're going to see a very typical feature. Now, here I mentioned neutropenia again. In any of these cases, the white blood cells may be increased or low. This is also usually mostly associated with neutropenia, because even though we might have high levels of leukocytes, most of those leukocytes are actually going to be lymphoblasts, but the normal healthy white blood cells are going to be suppressed. We know that neutrophils are the most abundant white blood cells, so it makes sense that these are going to be the most suppressed, which can lead to neutropenia and lead to recurrent infections. Like I mentioned, so we have a patient which we suspect acute lymphoblastic leukemia. We need to do a peripheral blood smear, okay, when we look at the morphology. And this is essentially going to give us a diagnosis, okay? We're going to see these immature looking cells, okay, lymphoblasts. Now, this is not enough to make a definitive diagnosis, okay? We need to know if these are actual lymphoblasts, okay? In some cases, these might look like myeloblasts or promyelocytes. There are some morphological differences. For example, promyelocytes are going to have arrow rods, okay? Any of the precursor myeloid cells are going to have granules. They're granulocytic, right? So this pretty much looks like a lymphoblast. However, I need to know if it's a B cell or T cell. Epidemiologically speaking, I know B cell ALLs are much more common. They make up 85% of ALLs, but I still want to confirm that, okay? This is going to lead us to do a flow cytometry, immunohistochemistry. I want to know if this lymphoblast, in fact, is a pre-B cell or a pre-T cell. Why do I need to know this? Because this is going to tell me how I'm going to approach the patient for treatment. Now, in this particular case, these are actually B cell, this is a B cell ALL. How do I know this? In the flow cytometry, okay, we detected these surface markers, CD10, 19, and 20, as well as transcription factor PAX5. Now, we're going to talk a little bit more about this in the next slides, okay? It's CD10, CD19, CD20. What is this? This is a surface marker of cluster differentiation, okay? All of these cells, okay, have different markers which let us identify specifically what subtype of white blood cells we are talking about, okay? Bone marrow is going to be part of the diagnostic approach, okay? Essentially, we're going to see that the bone marrow is going to be taken up by lymphoblasts. We're going to have very little adipose tissue, okay, very little other type of cells. We're going to see a hypercellular bone marrow made up of lymphoblasts. Okay, now, going back to the immunohistochemistry, this is very important for immunophenotyping the type of ALL we have. There are many markers, okay, we can consider. The most important markers are going to be markers for B cell ALLs and T cell ALLs, right? Now, it's actually quite simple. This is a simplified version of a flow cytometry, all right? We have two axes, right? X and Y axis, okay? Or horizontal, vertical axis, horizontal axis. I'm gonna say that instead. Here, I'm gonna mention, okay, what is intracellular TDT? Okay, TDT is a marker for lymphoblasts, whether they be pre-B cells or pre-T cells, meaning it's not specific either, okay? CD10 is also a marker for pre-blast or lymphoblast. Now, CD19, CD20, CD22 are specific markers for B cells, okay? Now, if we look at a horizontal axis here, anything, okay, to the right of this middle vertical line, okay, means that these cells have markers for TDT. Anything on the vertical line above this threshold means that these cells have positive markers for CD22, meaning these groups of cells have both markers for TDT and CD22. What does that mean? Well, TDT means that these cells are lymphoblasts, and CD22 means that these are pre-B lymphoblasts, okay? So this large population of lymphoblasts are actually pre-B cells. So our diagnosis here would be a B cell ALL, all right? Let's look at this here. Once again, CD10 it's a very general marker, okay, for precursor to lymphoblasts, okay, and CD19 is a specific marker for B cells, right? So this large group of population of cells, okay, are positive for both CD19 and CD10, meaning this is a B cell ALL. Now, if we were talking about a T cell ALL, okay, this would be positive for CD3. There are more markers for T cells. There's CD2, CD5, CD7, okay, which can all be positive. Even CD4 and CD8, which of course we know those are more mature T cells, right? And of course, for it to be confirmed with T cell ALL, this would have to be negative for any of the B cell antigens. Now, look at here, MPO. I mentioned an MPO in both B cell ALLs and T cell ALLs. These have to be negative. Why are these going to be negative? Well, MPO is going to be a specific marker for myeloid cells. Okay, so I also want to rule out that this is not actually an acute or chronic myeloid leukemia, that these are in fact lymphoblasts and not myeloblasts or promyelocytes or any other precursor of the myeloid cells. So MPO would be positive for any myeloid cells, okay, but would have to be negative for any of the lymphoid progenitor cells. Okay. All right, so prognostic indicators for ALLs. So now that we've made a diagnosis, okay, we've confirmed this is a B cell or T cell ALL. We need to look at the prognosis, okay, and we need to establish a treatment protocol for our patients. Now, prognostic indicators for ALLs take in consideration age. Age is very important, okay? Patients younger than 2 years of age diagnosed with an ALL have poor prognosis. Older children or teenagers or adults, okay, tend to have a poor prognosis for ALLs. Children diagnosed with ALL between the ages of 2 to 10 tend to have a good prognosis, so that is very important. Like we mentioned previously, WBC count, white blood cell count, okay? A low white blood cell count upon diagnosis tends to be a good prognostic indicator. A high WBC count upon diagnosis, typically greater than 50,000 white blood cells, tend to have a more poor diagnosis. Immunophenotype, meaning, okay, we already categorized our ALLs into either B cells or T cells ALLs. B cell ALLs tend to have a better prognosis than that of its counterpart, which is T cell ALLs, okay? And karyotype and cytogenic abnormalities, which we're going to look at next. This is huge. This is extremely important, okay, especially nowadays. Treatment protocols depend on cytogenetic abnormalities, okay, or cytogenetics. Not only do we have a specific diagnosis, okay, we need to look at the actual genetic aberrations or chromosomal abnormalities that led to this particular ALL. And we need to know this because this is going to define the treatment plan for the patients. Okay, so let's look at some of the more common, okay, cytogenetics, okay, for B cell ALLs, which are more common. These are usually associated with a favorable prognosis, okay. Translocation of chromosome 12 to 21 is the most common genetic aberration, okay, which will lead to a B cell ALL, and this will result in a specific fusion gene called the E2V6 RONX1. For those of you who are medical students, okay, and plan to take steps in the future, this is a high yield question that you probably will see many times in your Q banks and your tests later on, okay. Now, for us to, so for part of the diagnosis, like I said, is cytogenetics. In this particular case, for us to detect this translocation, the patient needs to undergo an RT-PCR or a FISH analysis, okay? Another chromosomal aberration that might be associated with BLLs, which has a good prognosis, is translocation of 119, not as common, okay? Or patients who present with hyperdiplety, okay, which result in more than 50 chromosomes, that can actually present up to 65 chromosomes. These actually tend to have a good prognosis when diagnosed. Now, associated with poor prognosis. Associated with poor prognosis, okay, we have translocation 411. Now, this is a poor prognosis in both adults and also poor prognosis in children. Another translocation, which you've probably heard of before, is translocation 922. This will result in the formation of the Philadelphia chromosome. Now, if you've gone over any hematology subjects previously, you know that this translocation is actually mostly associated with developing chronic myeloid leukemia. This translocation will result in the formation of the BCR fusion gene, okay, which will lead to the usually gives rise to chronic myeloid leukemias. In this particular case, in some cases, this can lead to a B-cell ALL. It is more common in adults than in children. In adults who do present this chromosomal aberration, they can actually have both features of an acute lymphoblastic leukemia and that of chronic myeloid leukemia. Okay, so that is interesting. This unfortunately is associated with poor prognosis. Prognosis is associated with patients having recurrent relapses, okay, in their actual leukemia. Another translocation that I failed to mention here that also is associated with poor prognosis is translocation 814. Now, translocation 814 is associated with another lymphoma, which is Burkitt lymphoma, okay, meaning it can present both features of an ALL and Burkitt lymphoma, also associated with poor prognosis. So cytogenetics is very important because these different, okay, chromosomal aberration genetic features will govern, okay, the treatment plan for any specific patient. All right. So that is, I know it's, we could probably talk about this much longer. We're not going into the treatment plans, okay? We'll suggest on the approach to a patient with an ALL, okay? I hope you enjoyed it, and I am open to questions. Dr. Alvarez.
Thank you very much, Dr. Herrera, who has given us a clear and short approach to this condition. We have now space for a couple of questions, so feel free to write them down so Dr. Herrera can read it, or if you prefer, you can also make it directly on the mic.
Okay, thank you, Dr. Herrera.
Yes.
Does anyone have a question?
Yes. I would like to know how to prevent tumor lysis syndrome in these patients.
Okay, tumor lysis syndrome is actually going to be more commonly presented, okay, in lymphomas. In this particular case, we mentioned that T-cell ALLs can present as lymphomas, as a more solid tumor. These particular patients, it's not quite as common in ALLs. We worry about other things in ALLs, okay? There are newer therapy approaches, alternative approaches such as CAR T-cell therapy, for example, which actually result in cytokine storms, okay, or excessive cytokine release. Tumor lysis syndrome, like I said, it's not going to be as common, especially not B-cell ALLs. It can occur in T-cell ALLs because they are more solid tumors and present as peripheral lymphomas. As for the prevention of this, I'm not sure I could give you enough information or concrete information on how this is prevented. Like any tumors, I'm sorry, the train's coming. Apologize. Like any tumors, this is a multidisciplinary approach. Hematologists, oncologists, internal medicine. These patients, we have to undergo frequent lab studies, right? We know that these patients can present with acute renal failure due to hyperphosphatemia, hyperkalemia, hypocalcemia. So the best way to approach these patients is simply having a good good multidisciplinary team, okay, and be in constant watch for any of the side effects associated with chemotherapy. In this particular case, like you're mentioning, tumor lysis syndrome, which for those of you who don't know what this is, this occurs when a tumor is being destroyed and the tumor releases, okay, nucleic acids, resulting in hyperuricemia, hyperphosphatemia, hyperkalemia, hypocalcemia, which we know can take the patient into acute renal failure.
Okay, thank you very much. Anyone has another question? We have a space for one more.
My question, can I ask?
Yes, go ahead.
Thank you. I would like to ask, what is the relapse of in children and adults?
Okay, so children, like I said, so when we approach the patient, or when a patient is approached, like I said, a children between ages 2 and 10, okay, usually present with B-cell ALLs. These patients actually, okay, have remission during the induction phase of chemotherapy, meaning even though the ALLs tend to be aggressive, okay, the chemotherapy is successful, okay, and a lot of these patients who are children actually do go into remission during the induction phase, right? For those of you who haven't heard of this before, chemotherapy, in this particular case, ALLs, we have induction, okay, we have consolidation and maintenance phases, all right? However, in adults, adults tend to relapse more commonly. They tend to relapse even during the maintenance phase, okay, or even during the consolidation phase. And this particular adults, there are new therapies, okay, trying to be developed to reduce this incidence of relapse. There are a lot of there are new medications associated with immunotherapy. There's a lot of exciting new information associated with CAR T-cell therapy, which is tumoric antigen T-cell therapy, which is very exciting news, but this is more specific for B-cell ALLs. Okay, so of course, adults do have poor prognosis, and they tend to have more frequent relapses than children.
Thank you. We have another question in the chat.
If you want, I can read it for you.
Yes, please.
Oh, yes. So, Dr. Herrera, I have a question that is there an easy or clear-cut way to clinically differentiate a B cell from a T cell ALL before doing cytogenetics or bone marrow aspirations?
Yes.
Is there like a clinical way to know or to have an idea of which one it is?
Yes. So we know that B-cell ALLs originate in bone tumor. Okay, so bone pain is going to be, for example, is going to be a cardinal symptom of a B-cell ALL. And for example, T-cell ALL, we know that T-cells differentiate in the thymus, so they might present with a mediastinal mass, okay, which might be seen on imaging studies such as MRI, CT scans. It might be associated with symptoms that of a mediastinal mass, such as difficulty in respiration, superior vena cava syndrome. So yes, there will be specific clinical features that might differentiate these, but of course that is not enough to confirm a diagnosis.
Okay, just one more question and then we're out. It says, it's in the chat. Doctor, what do you think about the use of granulocyte colony stimulating factor as therapy?
Sorry?
What do you think about the use of granulocyte colony stimulating factor as therapy?
I'll say, so I'm guessing you're talking about filgrastim specifically, which is widely used. Remember, this is not actually therapy for the ALL, okay? Why is a medication such as filgrastim used? When using chemotherapy, and actually the ALL itself is going to suppress bone marrow function, right? And one of the most severe side effects is going to be neutropenia, whether caused by chemotherapy or caused by the actual tumor itself. So medications such as filgrastim, which are granulocyte colony forming precursors, these are going to greatly help, okay, in the immunocompetence of an individual. What do the medications do? They try to increase the actual number of neutrophils. But like I said, this particular approach is not an approach to eradicating the ALL itself. It's an approach to increasing the number of neutrophils so the patient can continue to be an immunocompetent individual. We know that one of the most serious side effects, neutropenia itself, can lead to death, right? Can lead to serious infections. Patients with agranulocytosis, which is severe neutropenia, do need to be hospitalized, and they do all need to receive these types of medications.
Thank you, doctor. Well, for any doubt you may still have, send an email to cerebrumcytum@gmail.com and we'll forward the questions to the doctor and publish as a post with the answer. We're now done for the day. Thank you again, everyone. We have an agenda full of experts coming up, so stay tuned for the updates. It would be wonderful if you have 2 minutes to fill out the form I'm attaching to the chat. That way we can always achieve quality on this session. This video also would be uploaded to YouTube channel name, guess how, Cerebrum Saitum. Have a good day and weekend and look after yourselves. Thank you.
Okay. Thank you very much. Bye.